Hello everyone, I'm Dr. Juma Bishwas. I'm the mentor of MRCUG Health. Today I will discuss one of the very important topic of RCUG guideline, that is prevention of early onset neonatal GBS streptococcal disease. So why it's called early onset? So if any baby getting infections within 7 days of their delivery by GBS, that we mention early onset neonatal GBS infection. And as you know that this is the most frequent cause of severe early onset infection in newborn. And overall incidence, you can see it's highest in Black African ancestry and the lowest in South Asian ancestry. On an average in UK, you can see every month 43 babies develop early onset GBS infection. Among them, 38 babies make a full recovery. 3 babies survive with long-term physical or mental disabilities, and 2 babies die from their early onset GBS infection. And overall incidence is 0.57 per 1,000 in UK and Ireland. However, if any woman having infections or fever during intrapartum period, the risk is more, like 5.3 per 1,000. In case of preterm labor, the risk is 2.3 per 1,000. So you can see overall incidence is low, but if any woman having sepsis or preterm labor, the chance of getting GBS infection is more. And these are the risk factor of GBS infection. Like if any previous history that baby having infections with GBS, if mother carries GBS infection in her urine or in a vaginal swab, any preterm labor, prolonged rupture of membrane, suspected maternal interpartum infection, including suspected chorioamnionitis and pyrexia. So, however, as though this infection is more serious for the baby, but we don't do any routine screening, it's not recommended, as because many women carries GBS, but their baby is born safely. Even 17 to 25% women who have positive swab at 35 to 37 weeks, they become negative at delivery, and who actually negative at 35 to 37 weeks, 5 to 7% women will be GBS positive at delivery. And if we give all GBS carries women interpartum prophylaxis, there will be a very large number of women will receive treatment, but actually they do not need that, and that can increase adverse outcome to mother and baby. So that's why routine screening usually not recommended. But obviously, if there's any risk factor that can increase the risk of having GBS infection, we actually offer interpartum prophylaxis. So who are those women? So you can see that if the woman previous infant with invasive GBS disease, in that case, they offer interpartum prophylaxis. In case of preterm labor, we offer interpartum prophylaxis. GBS carriers identified in a previous pregnancy. So in that case, there's 2 options for them. Either you can offer them interpartum prophylaxis, or you can do a screening test at 3 to 5 weeks prior to the delivery. That is usually between 35 to 37 weeks. So either you can offer them interpartum prophylaxis, or you can screen them for GBS infection. In case of term delivery, if you see that there's a preterm pre-labor rupture of, the pre-labor rupture of membrane, in that case, if you see that they are known GBS carrier, in that case, you have to start immediately interpartum prophylaxis, and you have to augment the labor as soon as possible. Okay, so you can't wait for spontaneous onset of labor. You have to start the process of induction. Unknown or negative for GBS status, they don't need any interpartum prophylaxis. If patient in labor, no risk factor for GBS, no need of interpartum prophylaxis. But if patient develop fever or any sepsis, they need a broad spectrum antibiotic which can cover GBS infection. GBS carriers in the current pregnancy, they also need interpartum prophylaxis. Any woman who diagnosed with GBS infection in her urine, so you have to give her oral antibiotic antepartum period, and you also have to offer them interpartum prophylaxis. Any woman undergone a planned cesarean section, they don't need interpartum prophylaxis. So in a short, if any woman previous baby with a GBS infection, history of preterm labor, GBS carriers in her previous pregnancy, either you can offer antibiotic or you can do a screening test at 35 to 37 weeks. Preterm pre-labor rupture of membrane, known GBS carrier, intrapartum pyrexia, or GBS carriers in the current pregnancy, or it is diagnosed in her urine. In that case, they need intrapartum prophylaxis. So, even if the woman having GBS infection, that will not affect their mode of delivery and also the method of induction. And it is also not contraindicated, that is membrane sweeping and also birth in pool. And as I mentioned that if any woman planning for cesarean section, they don't need any antibiotic prophylaxis for GBS. So for the intrapartum prophylaxis, the first line medication we prescribe, that is IV benzyne penicillin. If they are not allergic to penicillin, dose is very important. That is 3 gram after onset of labor and 1.5 gram 4-hourly until delivery. Optimize the efficacy. You have to give the first dose within 4 hours prior to the delivery. As an alternative, you can also prescribe amoxicillin. If any woman allergic to penicillin, you can prescribe cephalosporin, that is cefuroxime 1.5 gram loading dose followed by 750 milligram every 8 hourly. Allergic to beta-lactam, you have to prescribe IV vancomycin 1 gram 12 hourly. Clindamycin, no longer recommended because the current rate of resistance is 16%. So nowadays, we don't recommend clindamycin. If any woman allergic to penicillin, give her cephalosporin. Allergic to beta-lactam, give her IV vancomycin. These are the symptoms of GBS infection. If you see any symptoms of that, you have to suspect that the baby getting infection. So either any abnormal behavior, unusual floppiness, difficulty with feeding or tolerating feeds, abnormal temperature, either very low, less than 30 or more than 38 degrees Celsius, has rapid breathing or has change in skin color. Any woman who received intrapartum prophylaxis more than 4 hours before delivery, their baby doesn't need any monitoring. But if a woman doesn't receive any prophylaxis, their baby needs to be monitored for 12 hours. That is 0, 1, 2 hours and then 2 hourly until 12 hours. Regarding postnatal antibiotic prophylaxis, it is usually not recommended for asymptomatic term infant without any antenatal risk factor because chance of getting infection is very low, like 0.2 per 1,000. If you suspect any sign of early onset GBS infection, you have to start treatment within an hour of decision to treat with penicillin and gentamicin. If woman's previous baby with GBS disease, they also need monitoring for 12 hours, that is 0, 1, 2 hours, and then 2 hourly for 12 hours. And you can encourage breastfeeding because that is not contraindicated. So that's all for early onset GBS infection. Here, the most important is that you have to know that where you have to offer them intrapartum prophylaxis, what are the medications you can prescribe, and what are the symptoms of early onset of GBS infection and how you're gonna monitor the baby. So thank you for listening to today's video. I hope you enjoyed this video. If you have any question, you can ask me on the comment box. I will happy to answer all of your query. Thank you.